life-saving tool. So I have invented. So being a professor in a medical college, and this program is held in a medical college itself. So I would like to enlighten our fellow dear students with the most basic technique of awake blind nasal intubation. So whenever we see, we talk about awake blind nasal intubation, prima facie it looks scary, sounds scary. Everyone is like a bit of stressed. Arey hoga, nahi hoga. But as the saying goes, difficult road always lead to a beautiful destination. So we'll start. So objective, we will be learning about the history, statistics, indications, contraindication, the required things, equipment required, anesthetic drugs, the actual procedure, what can be a troubleshooter in this blind nasal intubation, and last not the least, we will be discussing about the focus on vessel. So it was first reported during First World War in 1902. Then for next 18 years, Rowbotham and Magill developed the technique for nasal intubation. But after the invention of succinylcholine, blind nasal intubation was replaced by rapid sequence intubation. But it's not always 1 plus 1 is not always true. Even after the invention of the orotracheal intubation, we invited another complication associated with it was cannot intubate, cannot ventilate situation. But with the advent of at that time, blind nasal intubation lost its stardom somehow. But then again the blind nasal intubation started regaining the market. Then after invention of fiber optic bronchoscope, the technique of awake blind nasal intubation has become an old school, but still in third world countries like India, where there is unavailability of modern armamentarium in the with the anesthesiology person like video scopes and fiber optic bronchoscope, blind nasal intubation is a saving technique for the anesthesiologist himself. Statistically, in a retrospective study, 500 patients underwent head neck surgery, out of which underwent fiber optic nasal intubation. 64% was the number. So it highlights the importance of awake nasal intubation using a fiber optic intubation. But considering fiber optic intubation is not everyone's cup of tea, again the blind nasal intubation remains a viable option wherever fiber optic is absent. So light ward guided and blind nasal intubation in maxillofacial surgery with difficult airway blind technique has a success ratio of first attempt with 65% and overall success rate is always like distinction 76%. So indication, obviously difficult mask ventilation, difficult intubation, severe risk of gastric aspiration, especially in a patient who is known tobacco chewer having severe submucous fibrosis and coming for laparotomy. Facial trauma, especially the Leefort 2, 1 and 2. 3, 4 are like a pan-facial trauma. So won't be attempting blind nasal intubation. Straightway we will opt for submental intubation. Airway trauma, of course. Nobody will dare to give propofol in a severely hemodynamic unstable patient unless securing the airway. So here blind nasal intubation is very important. Unstable cervical spine, though it is not proven, they don't say attempt of intubation is detrimental in cervical spine pathology, but we should not test the poison always. Intraoral mass lesion, limited mouth opening as the patient with trismus or submucous fibrosis. Absolute contraindication for the very obvious reason you won't be attempting it in severe epiglottitis. Patient will start bleed. Mid-phase instability like Leefort's fracture grade 3 or 4. Coagulopathy, you won't risk you can't afford the risk of bleeding. Suspected basilar structure, skull fracture being a blind procedure, you may end up entering the skull cranium itself. Relative contraindications is large nasal volume. You will opt for other side nasal entry. Suspected nasal foreign body, recent upper nasal surgeries, upper neck hematoma, history of frequent episodes of epistaxis pointing towards the coagulopathy. To start with, written, valid, informed consent has to be taken. It's a golden rule. It elevates 90% of the fear of the patient and 90% of our problems. Prerequisite: table with adjustable height, especially the head up, head low, sufficient oxygen and means to deliver it, preferably the oxygen nasal prongs, suction machine with red rubber catheter as it is less traumatic. We generally differ from using the routine catheter, it may cause trauma. Anesthesia drug, the dexmedetomidine is required in conscious sedation to patients who are anxious. Equipments to provide ventilation. We have a mnemonic CCC salted PSM. So each alphabet in this stands for central cylinder circuit, suction airway laryngoscope, endotracheal tubes, and emergency drugs, spine sticking monitor, and drugs for giving anesthesia. Another, there is list to be very specific, warm water bucket to soften the tube to make it less traumatic. If you are planning having a bit of mouth opening, the laryngoscope is used. Capnography being a gold standard for confirmation of tracheal intubation. If the condition permits, you must have it. Anesthesia machine, suction ambu bag, etiosterilized vessel if you are using it for the second time. Rule says before giving anything in anesthesia, you must calculate the dose. So after calculating the toxic dose is for anesthesiologist himself. He is not supposed to exceed that dose. For patient, we have per kg milligram doses. Xylometazoline is for decongestion. I prefer 5% lignocaine ointment. It anesthetizes the nasal mucosa very effectively. 4% lignocaine solution for transtracheal block. 10% lignocaine solution for anesthetizing the oropharyngeal airway. So the difference of 4% and 10%, 4% for trachea and 10% for oropharyngeal passages is because the secretions tend to dilute the lignocaine solution. So that's why we prefer 10% in oral cavity. 2% lignocaine with adrenaline for the very obvious reason of nebulizing and shrinking the nasal mucosa. Ondansetron as an emetic, never forget to give glycopyrrolate. It's a very important drug for awake blind nasal intubation or any general anesthesia condition. Then dexmedetomidine for conscious sedation, angiolysis and butorphanol for analgesia. Once the tube is in, the patient tend to cough like anything if your airway block is not so perfect. So you have to keep the syringe of propofol attached to the patient. Vecuronium, obviously, we won't give scoline once the tube is inside. We can safely give vecuronium as per the dose recommended. Procedure, I prefer starting overnight nasal decongestion, but not like patient la ratri utun nakat drop टाकणे, but at least आदल्या दिवशी 2 वेळा सकाळी एकदा. Once inside the OT, nasal prong with oxygen supplementation should be applied to the patient because the dictum means failure to intubate do not kill the patient. Failure to oxygenate kills the patient. You always keep it in mind. Pre-medication with anti-Silavog and anti-emetic medication given. Left nostril was selected as per the ENT reference. They examined the nasal cavity and there was DNS towards the right side. Even bedside you can do. You can ask the patient to obstruct each nostril alternatively and ask him, तुम्हाला कुठल्या नाकातनं श्वास घ्यायला बरं वाटतंय. So then also you will be able to identify the patent one. Nasal airway, serial dilatation, last one being the bigger than endotracheal tube, expected endotracheal tube. But personally, I feel nasal airway is for giving you direction in which you should go. It being a very soft structure. It don't actually dilate the airway, all the terminates and all that. And make sure you make it slippery with 2% lignocaine. While inserting, tip of the nose should be pulled towards the anesthetist, so the chances of airway entering in the inferior turbinate, which has maximum space as compared to above turbinates, increases, making awake blind nasal intubation relatively less traumatic. We should always try for atraumatic only, but things are never in our hand. The nasal airway should be directed toward the occipital protuberance for the obvious reason to enter in the maxilla inferior turbinate. It should be left in 10 minutes, let the whole airway gets anesthetized, because lignocaine jelly takes time to act. 10% lignocaine, 4 puffs, 0.1 ml lignocaine gives 10 mg of lignocaine to each time you puff. So 40 mg should be sprayed on the posterior most part of the pharyngeal wall to it anesthetize the pharyngeal wall, some extent of glottic opening and vocal cords. Personally, this is very important because when you inject transtracheally, superior surface of the vocal cord may not get anesthetized. Even if you ask the patient to cough vigorously, when he is coughing, he is alternately contracting his vocal cord also. So I prefer giving instillation of lignocaine from above also. Knack for transtracheal block is you have to stabilize the needle base with your hand, non-opposing hand. So when you are injecting, patients start coughing. So with stabilization, the needle don't move or come out of the trachea. So your 2 ml or 3 ml drug is 100% deposited in the trachea only. Nasal airway was removed. The tube was endotracheal tube is softened and it is lubricated with 2% lignocaine jelly. If you have luxury of using North Pole tube, always prefer that, but sometimes we can't. Once the tube is in cricopharynx, we ask the patient to extend his neck and protrude his neck. It mimics the action of laryngoscopy. What actually the laryngoscope does? You extend and you lift the epiglottis. Tracheal intubation was confirmed with whistling sound, air mist and capnography and inability to vocalize. Once you are in front of the vocal cord, when you have whistle with you, whistle will start making noise slowly. You just have to follow the voice, and once you enter, the patient coughs vigorously, you are inside. So this was the first case we intubated with whistle. You want to redo surgery for commando patient. Now there are some troubleshooters. When the tube is abutting at the vallecula, you are moving whole larynx with your tube movement. So flex the neck slightly, try again, can manipulate the larynx externally as an aid. When the tube is in either paraglottic space, the protrusion will be seen to the corresponding side. Either you retract the tube slightly and turn the neck towards the side, or you try turning the tube. When the tube is in vocal cord, no movement will be seen and patient will be able to vocalize. There are some maneuvers. You can extend the patient's neck with the bolster below his chest. Try again. Or you can retract the tube, inflate the tube with 20 to 30 ml of air. So the tip gets lifted upwards towards the vocal cord and try intubation. Now we will be focusing on Dr. Dambale's whistle. Initially it was HD's whistle, but HD was sounding more like a lady and all that. So my friend suggested, boss, you give your name. So I renamed it as Dr. Dambale's whistle. So how the idea stuck? My daughter wanted me to blow a whistle she bought from a local there is a fun fair in Nasik. So I refused, like I refused cases in OT also. Himal nahi karaycha. But she was my daughter. She forcibly inserted that whistle in my mouth, and there was some dirt on that whistle. So it irritated my posterior pharyngeal wall, and I coughed out loudly, and the whistle blew. So it was very shocking for me. How you can do this? I shouted at her. But after 10 to 15 minutes, the tube light started blinking in my mind. Boss, we do this regularly. Why not try this something like this in while doing intubating a patient awake? Because being a tribal hospital, being a patient being very illiterate and poor, they don't give so much importance to their oral hygiene plus their tobacco chewer. So we have n number of cancer patients in SMPT. So as a rule, we generally do at least one awake nasal intubation daily in SMPT. So I took the whistle to SMPT. First I tried the endotracheal tube angle connector and whistle. I have tried to connect them together with a paper sticky. So tube went inside, but whistle didn't make any sound. So next time I tried with Dynaplast. Again tube was inside, but whistle was not making noise. So I went back to physics and googled the physics of behind the whistle. So here it was clearly mentioned that there should be no air leak this time. So I asked Avinash Dole what to do. So he suggested me, sir, आपण MSIL लावून बघूया. So we applied MSIL and got a airtight chamber. And this time the whistle blew, and everyone was very excited. Wow, you have a nice jugaad it was. So we searched on then we started searching on the literature. There were some air amplifier available, but this kind of device was not available. So we decided to add a oxygen port in it, because there is a risk of desaturation even without anesthesia in COPD, obese patient, pregnant patients, or patient with cardiac abnormalities. So we decided to add an oxygen port, but oxygen port again had the risk of leak and whistling itself. So this time also we went back to physics, and there it was mentioned minimum airflow required for making sound, it is 50 ml per second. So we opted only for keeping the oxygen flow of 2 liters per minute, so which gives you a flow of 35 ml per second. So we landed safe this time also. So this was our first baby whistle. Now the concept start making rounds in my mind. So let's proceed for prototype and patenting. Prototype makers were not readily available, accessible to us. For company people they are accessible. No, for doctors they are not accessible. So I went to a local toy manufacturer. He शिट्टी बनवतात कशी? But that time he told me, sir, तुम्ही डॉक्टर आहात तर तुम्हाला ह्युमन ग्रेड प्लास्टिक लागेल, त्यामध्ये 3D डिझाईन्स असतात, लिक्विड रेजिन्स असतं, आणि then we made the final prototype. So regarding the patent, I was very novice during the patent filing. It took us 3 months to reach the patent attorney. The lawyer who files the patent for any instrument is called as patent attorney. And the patent was published within 15 days. Now it is published and available to public online since last 1.5 years. And it is safe also. So I have waited for almost 1 year to make it available to others. So nobody could copy it. Now you can access it by putting a patent number. Physics, As the air from the trachea enters the vessel at one end, reaches the other which is closed, or air molecule piled up on top of each other, creating a high pressure region. When the pressure exceeds the atmospheric pressure, the air exits making a noise. So we have the small ball is added to make add a trill to the sound. So you get over there. It's like a pressure cooker only. And the sound confirms that air continuously can be supplied from trachea only, not from the esophagus. So endotracheal tube is endotracheal placement of the tube is confirmed. Now the advantages: time required is hardly 1 to 5 minutes. It is highly cost effective. Airway blocks makes the magic most of the time. Learning curve is much shorter. Inline oxygen supply to the patient is possible. Whistling sound diverts the patient's attention and increases cooperation for the procedure. Even a trainee doc can do it hassle-free. Disposable or can be etiosterilized. No risk of cross-contamination and damage like fiber optic bronchoscope. Zero maintenance can be available in remotest possible setup. Even ENT and surgery resident, when especially they are doing revision tracheostomy where there are high chances of false passage, it can be used as a confirmation. In mass casualties also it is very important, because when you have 10 patients with facial trauma, you cannot afford to intubate everyone and auscultate in that noisy environment of casualty. So you just intubate, you apply the whistle, yes, confirm, go ahead. You apply the whistle, confirm, go ahead. Even sometimes in casualty or during my JR shift, laryngoscope light was always going switched off or somewhere or somehow the laryngoscope not working for me. If it happens in casualty scenarios, you won't require laryngoscope fully littered over here also. The sound will assess you. So this being so cost effective, this whistle can be used in PHC, RH, even roadside accidents also over the period. So there are some procedure, there are some videos I would like to show them. Administration of 2% lignocaine jelly. Nasopharyngeal area. I have pulled the tip towards that. See, I hold the base of the tongue. So even if the patient is coughing, that is 10% log spray. I again still 4% lignocaine because we did not give nebulization over here. Lubricate well. Voices. That is EtCO2 validation. You can attach a oxygen port and EtCO2 port. Beautiful air mist you are able to see. This is another one. This patient was intubated within 14 seconds. The moment tip of the tube is in front of the vocal cord, visual side starts making noise. It is actually torch bearer, as we say. Is the sound audible? Now, I have almost distributed almost 300 to 350 whistles all over the country. So these are the splendid responses. This is from Orissa. This is from Gujarat. That is Dr. Tarun Waghela. It's only for 2 fracture. I intubated this patient. This is for tracheostomy. The ENT resident is so excited. This is for ICU intubation. This was done by Manisha Katikar madam. They use for as a extubation guide also for weaning the patient for tracheostomy. He is Dr. Ashish Naik. He is intensivist in Nashik. He uses this whistle for weaning also. This whistle actually guides the anesthesiologist to assess the quality of reversal also. The more sound, the better is the reversal quality. So this is JR2. So learning curve is relatively very shorter for this. JR1. Avinash is also there. Sir is also there. Bala sir and his team recently visited Tanzania. They took the whistle over there. It was demonstrated in Tanzania anesthesia hospitals also. That is Dr. Apex Patwa. We conducted a Google survey. Around 296 anesthetists participated. So there were some questions. So will it be helpful to in every for every question we scored almost 90%. If you are getting a 30% marks in such surveys, the device is useful as per the market expertise. Will it be useful to carry to possible? Will it be useful and carried to the possible remote location where fiber optic is not available? 98% public agreed yes. Is supplying oxygen through this device in line is beneficial as compared to fiber optic? Even 96% people say yes. Will the intensity of sound made by whistle, though very subjective, will guide the anesthesiologist for proceeding to the extubation after reversal? 86% agreed upon this. Do you think it can be an alternative to fiber optic bronchoscope, considering the price of fiber optic bronchoscope and infrastructure of hospital, where fiber optic bronchoscope is not readily available for difficult airway cases? So 80% people agreed on this. When I was doing my bond in the Government Medical College Aurangabad, some patients were referred to higher center purely due to unavailability of fiber optic bronchoscope. With whistle, nobody can claim 100% success ratio, but yes, definitely I am saying it intubates 95% of the patient or more when the anesthesiologist is competent and confident. So definitely, it's a very good. Yeah. Will it be helpful to confirm the position of tracheostomy tube in airway? Spontaneously breathing patient, 91% said yes. Thank you so much.